Good afternoon. My name is Julian Harris. I am the president of a company called CareAllies. I'm a primary care physician trained in internal medicine at the Brigham in Boston, and had a chance to practice at a community health center associated with the Partners Health System, and to work at the Cambridge Health Alliance as a hospitalist. But from a policy perspective, I was really fortunate to run the Medicaid program in Massachusetts for 2 years and to get to work with colleagues, now friends at CMS, to stand up the country's first Medicare Medicaid duals demo, which I'll talk about in just a bit. And then got to go to the other side and go run the healthcare team in the Office of Management and Budget, which if you don't have context for OMB is kind of this secret box behind the federal government, pulling lots of strings, hopefully for the good, but very involved in most aspects of federal policy from a budget perspective and a policy and regulatory oversight perspective as well. I'll talk a little bit about that. Had the fortune to come and run CareAllies, which is a company that works on helping providers with the transition to value-based payment and also does some direct primary care in the home for seniors, and I'll talk a little bit about that. But I really want to actually ground this, especially having been here this morning for Ralph, and I'm actually still reeling from that session, because it was so incredibly powerful. I want to ground this a little bit in a personal story as well. So had a very different experience watching my grandparents, my maternal grandparents, navigate the transition after my grandmother was diagnosed with Alzheimer's. And over the period of a decade, watched her, certainly her cognitive abilities, but over time her physical condition deteriorate really significantly. My grandfather, who had been an extension agent for the Department of Agriculture, insisted, despite having 5 kids, 2 of whom were in the area, that he was going to really oversee her care, and made that his life's mission. And so over the course of a decade, fortunately, and amazingly somehow, my grandmother, who was an elementary school teacher, bought long-term care insurance. And so she actually had long-term care insurance, which is a rarity. And so they actually were able to have home health aides come twice a day and help with some of the ADLs, but my grandfather did an enormous amount of the work himself, and certainly had some support from an uncle and aunt who were nearby. I thought I loved my grandfather. I knew I loved my grandfather, I guess I should say, before, for all the things that he did for us as grandkids growing up. I will tell you, I fell in love with him all over again over the course of that decade, watching him take care of my grandmother, but also watching their interactions with the healthcare system. And this is in part during my medical training and my residency training. One of the things that was so powerful was that they were able to engage hospice care, not as early as I would have liked and encouraged, but to engage hospice care. And I have really incredible memories of the time that the family spent with that team, making sure that my grandmother's last days were the way that she would have wanted. And I had a kind of opportunity personally to spend some time with her at the end. And I remember I sang, so I remember having the chance to sing some songs to her the last time we were together. And then a few days later, she was gone. These stories are so personal. We all have them. I'm sure everyone who was actually here for Ralph's session this morning was both thinking about this through your professional hats, but through the personal hats that every single person in this room wears, either as a child or as a grandchild or as a spouse. And so whatever roles we find ourselves in, I always encourage people to allow yourself space to stay connected to those personal stories, because they really shape the work and the way that you think about approaching these efforts. When we were standing up the duals demonstration in Massachusetts, if you don't have the context, you got to hear a lot of things about Massachusetts today, the most expensive state, an innovative state, et cetera, all true. But one of the things that's actually really unique about Massachusetts is there's actually an extraordinarily robust advocacy community across a really broad spectrum of issues in the healthcare and social services space. And when we started standing up our duals demo for people who were in the Medicare and Medicaid program, we spent an enormous amount of time actually engaging with a really diverse set of stakeholders. So we were focused on the under 65 population. We already had pretty robust programs actually for the over 65 duals population. And there was an advocacy group focused on people with behavioral health conditions, with physical disabilities, with developmental disorders. There was an advocacy group for the blind, for the deaf. There was an advocacy group for people who had multiple chronic conditions. Certainly all of the provider organizations that you would expect, the hospitals, the nursing homes, the home health agencies. Some you might not expect, podiatrists, but people were very engaged because it was such a big shift in the system. But one of the things I think that was a powerful lesson for us was that there were a lot of people who talked about and thought about the coordination of medical care and medical services. So how do people transition from primary care to the hospital, from the hospital to either the home or to a nursing home? But for people who had multiple chronic conditions and who had personal care attendants or home health aides who were very much a part of their lives, we learned a lot collectively about a sense of disconnect between the medical system and the world of long-term services and supports. And part of what we learned was that people who depended on those services didn't see those services as a part of their acute illness. So if they were going into the hospital for an episode of, and pick a condition, that was very different from, this is the person or this is the team of people who actually help me live my life every day. So there was an advocate named Dennis Heafy, who was very involved in the development of our duals demonstration, actually has been very involved nationally. Dennis has a number of chronic conditions and is just an extraordinarily powerful advocate because he really has helped people to understand that this disconnect between the medical services and the long-term services and supports really is something that you have to be thoughtful about as you're designing models. And so we created a role, and as you can imagine, there was a lot of debate and conversation about the name of this role, and we landed on the Independent Living Long-Term Services and Supports Coordinator, or the ILLTSS Coordinator. Mouthful, rolls off the tongue, right? But this person's job was to actually help think about, is this bringing back memories, Ito? Ito was on the duals team when we were coming up with this with the folks in Massachusetts, but the person's role was really to think about how do we actually make sure that that spectrum of long-term services and supports, by the way, that are not only disconnected from in many cases the medical services, but people didn't know of them. So I trained in Boston, and when I was running the Medicaid program, I would go back and give talks at some of the Harvard teaching hospitals and residency programs, and I would just show a list of the long-term services and supports that were covered benefits in Medicaid, and the same for some of the additional benefits from a behavioral health perspective, and just tick through it and ask people if they had ever heard of them before. And most of the trainees, and in many cases, most of the faculty had never heard of these services, didn't even know they existed, couldn't describe what it was. And so it was really challenging to kind of think about how they were going to be the people to help make sure their patients got access to services that they didn't understand or even know existed. And so this person's role was to actually make sure that as we thought about designing models, that we were ensuring that there was connectivity to and understanding of those services and ideally coordination with the medical services and vice versa. And so I think one of the areas that is an ongoing need is for us to recognize that our broader set of social services and long-term services and supports that we wrap around patients or members with complex conditions are often very disconnected, and we have to think about how we are connecting the dots. One of the other things that we found is that in certain cases, people had multiple care coordinators in their lives. So there were care coordinators who were assigned to them by state agencies, sometimes multiple care coordinators assigned by different state agencies, care coordinators who were assigned by health plans, care coordinators who were assigned by their providers. So there was this sort of cacophony of care coordinators, all trying to do the right thing and all trying to help any given patient or member, but not necessarily coordinated among themselves, or even, heaven forbid, knowing that they all existed and that they were all calling the member or the patient and trying to have an impact, a positive impact, but in many cases complicating the lives of people who already navigated a great degree of complexity. And so we sought to at least ensure that those folks had visibility into their shared existence and the need to think about how they work together. One of the other things that I think was an important lesson for us from a financing perspective, and I can say this now, having worked on the model from the state perspective and then going to OMB, is that I think in retrospect, we were overly ambitious in what we strove for in terms of potential savings in the design of the model. So if you take a population that has been underserved in fee-for-service for a significant period of time and you put them into a managed environment, it will take time to achieve savings. I believe that there's a potential for savings, but it can take time. And in certain cases, while there may be savings, they may not be as expansive as one would want, right? And so I think that was definitely a lesson learned from my perspective as we thought about what we were trying to do in the context of those models. I'll leave it there from a duals perspective. I'd say fast forward to the work that we do in CareAllies. So we spend a lot of time helping providers, largely physician groups, although some health systems, navigate the shift towards value-based payment. We have 200,000 people who are participating in the Medicare Shared Savings Program, and we're supporting the practices or health systems that work with them. And we have about 500,000 people who are in Medicare Advantage risk arrangements. But one of the things that I tell people is that when you think about asking physicians in particular to participate in population health, we weren't taught to do this in medical school. So the thing I often say to my team is, because a lot of the people who are working with the physicians are not physicians themselves, you have to remember that these folks got taught or were taught to take care of individual patients, Mr. Jones or Mrs. Gonzalez, not to think about, I have a population of 1,500 patients, 20% of whom have diabetes, X% of whom have COPD and on. And these are population level interventions that I or my care team can introduce. And so that's part of the journey that we take providers on. Most providers also don't go to business school. And so when you ask them to think about being responsible for the total cost of care, that's also a journey for them in terms of understanding that from a financial perspective. And so that work of bringing population level thinking and being really some financial savvy, as well as an understanding of accountability for the total cost of care is a big part of the work that we do. And then the last piece is, and this has been such a big theme today, but we send providers, we send physicians, primary care providers, but also nurses into the home to do risk assessments, to do primary care in the home, and it is extraordinarily complex. This is not something that you can just walk into the average primary care practice and ask someone to come out of the practice and do, because it's really a different skill set from practicing in a clinic setting. It's not something that everyone can do well, and it's not something that everyone would really want to do. And so actually finding the right workforce, and that's been a theme that's come up during the day, is really important. It's something that we find to be challenging, but important in our work. So I'll stop there.